All right. Good evening, everybody. Thank you for taking a precious Sunday evening for most of the Asian participants. Today, we are very honored and we are very happy to have invited Dr. Yoon. He's from Korea. I have known Dr. Yoon since about before COVID, at least 6 to 7 years when I visited his clinics in Incheon. Okay, Dr. Yoon is orthopedic by specialization, and his focus is expertise and on the MSK ultrasound treatment. Without further ado, I would like to invite Dr. Yoon to do his lecture. All right, Dr. Yun, you can share your screen, yeah? I will stop sharing my screen. And also please unmute yourself, Dr. Yun, okay? Yeah.
Mm, Okay. Today my topic is how to get the best result in stem cell therapy for MSK disease. Uh, my name is Yong Yun. I'm from South Korea. My clinic name is the Incheon Terminal Orthopedic Surgery Clinic. This is my journey. So I'm a conventional medical doctor. I undertook the orthopedic surgery residency. And then I learned the osteopathy and the regenerative medicine and the functional medicine also. So today I'll give you guys advice or some tips for regenerative injection or the stem cell treatment. And how can you get the best result or the optimal result after the stem cell therapy? So I'll give you some tips. This is my journey. I gave a lecture in European School of Prolotherapy. My content consists of these four topics: understanding the pathophysiology of the osteoarthritis and injection technique, and injection material optimization, and other methods for synergy. I don't know you guys' background because I'm an orthopedic surgeon, so I did many surgery or like the reduction and pinning or open reduction or closed reduction or external fixator. So I'm very familiar with the surgery. But family medicine doctors or other doctors are not familiar with the osteoarthritis and they don't some physicians they don't know the regenerative medicine. So I'll give us some tips and the basic stuff in this my presentation. Indication of the stem cell therapy is like this way. So atrophic vaginitis, lumbar HIVD, and anal fistula, and osteochondral lesion, and shoulder osteoarthritis, and hip osteoarthritis, and cartilage defect, and rotator cuff tear, or shoulder osteoarthritis. Like these indications include all of the disease in the musculoskeletal uh, only exception is a tumor or inflammation. So you can apply the stem cell treatment to the knee joint or the ankle joint or short joint and all of the joint and the disc. Oh, how much patient of the OA is occurred in every year, or the epidemiology or prevalence? In China, almost 15%. In Korea, 35%. I don't know why. Korean is very high. It's two times more than China. And United States is almost 13 or almost 15. But problem is if the people is aging older than 80 years and almost 50% of the people, they get osteoarthritis. That's the problem. And that's our market or our target of the treatment. And diagnosing symptomatic osteoarthritis only based on radiographic findings may result in its overall examination. So some patient has a very severe osteoarthritis, like the stage 4, like the bone to bone, but patient have no pain. So that's not our indication. Risk factors of the osteoarthritis like this way: aging and female and black people, low education, obesity, and trauma, and leg length discrepancy, and sports activity. High impact sports like the soccer, water wrestling, or handball, odds ratio is 5 or the 3. So 3 times more than normal people. And soccer is odds ratio is almost 10 times. This is a article of the OA RSI. They lived to 2021. Um, so I make the very simply like this way. So occupational risk, like the farmer or the builder, oh sorry, metal worker or floor layer, carpenter, miner, house worker, or service worker and craftsman, they will get osteoarthritis. And problem is age, sex, BMI, previous leg injury, and osteoporosis. And does cartilage loss cause pain in osteoarthritis? In orthopedic surgery world, we always said that we do not treat the X-ray, we treat the patient. So patient has the severe osteoarthritis, like the stage 3 or stage 4, but patient has no pain. Okay, we do not treat. Okay, just observation. Stem cell treatment is only one part of this article. And other things, OA and long-term condition is association with Alzheimer's disease. So patient has the long-time osteoarthritis. Patient will get the uh, Alzheimer's disease. So we should treat the osteoarthritis and other problems, comorbidity simultaneously. So in this situation, so stem cell therapy is the best option. Individual level osteoarthritis, well-being problem, and behavioral problem, and diet problem, and comorbidity problem will be occurred. And interpersonal problem is social participation is decreased, and patient will get depression. And healthcare system, so problem will be occurred. So in this situation, we should focus on the exposure of the interest. So worsening of the social economic circumstance, and the patient has outcome of interest. And before the severe osteoarthritis, like the stage 3 or the stage 4, we should approach to the osteoarthritis, like stage 2 or stage 1. And this is a gene problem, it's SNP. SNP is a single gene problem, so it is and identify casual regulated gene is a consider like this way. So every year we find out the SNP or the other problem, but problem is very complex. So RNA level is like this way, and microRNA level like that way, and gene problem. So it's very complex. So we are the physicians, so we always meet the patient in this stage: inflammation, cartilage degradation, and proliferation, ECM synthesis, and apoptosis stage. We should know the mechanics, because what is the exclusion criteria or the inclusion criteria of the stem cell treatment? Joint level biomechanics of the knee OA is this way. Using fluoroscopy, severe osteoarthritis also associated with the increased exterior external rotation and posterior translation during squatting. During gait initiation, individuals with moderate and severe osteoarthritis reduce the central pressure displacement and slower, longer lasting anticipatory postural adjustment. So it's like the osteoarthritis and joint instability is not well treated under the stem cell treatment. And we should know about the kinetic change: higher hamstring activation, greater lateral co-contraction, and prolonged quadriceps and hamstring extension activation. So after the 2 years or the 3 years, like the chronic stage of the osteoarthritis, and quadriceps hamstring will be wasted, and patient muscle problems is occurred simultaneously. In this situation, we should control the muscle, joint, ligament, all of these things simultaneously. And sustained knee loading was less dynamic and more sustained vertical ground relation pattern is observed. So gait retraining focused on cadence made us represent a novel intervention to improve mechanical loading in knee osteoarthritis. So after the stem cell treatment, we recommend exercise like the PNF, proprioception exercise, or the isometric exercise, and gait training. And biology, this is our major part. So overall joint homeostasis and bone formation, NGF, TRPV, only one part is regenerative therapy, stem cell-based therapy and biomaterials. We always inject to the intraarticularly. So why we inject the intraarticular? Because our problem, we think that the osteoarthritis is only occurred in the joint space and the cartilage, but problem is not only occurred in here. Because synovitis induced venous portal circulation and subchondral bone problem is occurred. So in this situation, subchondral bone sclerosis and nutrition is not going to the joint space and blood supply is problematic. So in this situation, only intraarticular injection is not working. And weight reduction is very important part. So if you're in osteoarthritis obese patient, BMI weight increase will increase the order of horizontal fissure by almost 15%. So patient maybe all physicians heard about that. If you lose your weight and your pain will be gone like that way. So in this situation, so if you remove or the liposuction of the abdomen fat and BMI is decreased and horizontal fissure will not be occur. So I strongly recommend the liposuction and the stem cell treatment because bone marrow aspiration is not affected to the body weight. This is osteopathy. Why is occurred? Because PLG4 expressing progenitors from synovial lining contribute to cartilage capping of the osteophyte, but not to bone. So in this situation, so we should control all of things together. So treatment method like this way, conservative treatment, physical therapy, and weight loss and exercise, medication and injection, surgical treatment. What is our target? Just intraarticular injection or subchondral bone? Intraarticular injection and subchondral bone marrow region. So they did a very interesting study. 50 patients, 50 years later, totally arthroplasty across blade, intraarticular injection only 70% to totally arthroplasty, but bone marrow region only 20%. Which one is the best target? I strongly recommend subchondral bone. And how much the cell number is the best for the patients? 1 billion or the 1 billion? Many plastic surgeons they think that more is better, but I don't agree with that because more cells will not affect in here because cell is injected to here, but because this space is very small and many cells is going into the very small space, there will be supply problem and cell will not get enough blood supply and oxygenation. So in this situation, cell is not working well. Injection technique is a palpation or the ultrasound guided injection. I strongly recommend ultrasound guided injection because cost effectiveness, more accurate and efficacious. This is a post-commit accuracy. So glenohumeral joint, almost 72% landmark guided injection. And AC joint, only 40%. I'll skip that. And injection of the hip, landmark guided injection, only 2/3. How about the knee? some articles say that only 56% or the only 50 or almost half. So if we inject palpation guided or the landmark guided injection, so your stem cell will not go into the joint or will not go to the intramedullary space. This is my preparation: betadine, propofol, alcohol, and I always use the 23 gauge needle. First step is a palpation. Ultrasound is here, quadriceps. So I palpated to the where's the joint and moving. And second step is aspiration. If you do not aspirate the fluid in the joint fluid, your stem cell is still diluted and it is not working well. And second problem is the cytokines. If your patient has the osteoarthritis, if you analyze your fluid, you can identify the cytokine problems. Third step is the ultrasound guided injection. Like this way, if you inject fluid or something and it is not swollen or the bulging, so powder flow, if you inject fluid, and like this way, I inject, but no bulging. This is an intraarticular injection. Oh, which one is correct? So this is all done by myself. This one and the one. Injection. This is bulging. This is not correct. That's why. So we should use the ultrasound because we don't have the enough stem cell, and this is a very, very high price procedure. So in this situation, we should use the ultrasound. And how about the nutrition? Healthcare professionals should consider promoting diet rich in fiber, including whole grains, fruit, vegetables, nuts, shit. Okay, there are many options, so I'll give you the advice. My protocol is this: patient has the atherosclerosis. You prescribe the enough water and vitamin C and vitamin D and vitamin K2 and helium and magnesium. For regeneration, enough water and vitamin C, D, and MSM, arginine, collagen. Neuropathic pain is different, so vitamin B and magnesium and omega-3 and coenzyme Q10. It is very important. If you want to get the best result of the stem cell treatment, before the procedure, before 2 weeks, you should prescribe these nutritions. And the injection material is like this way: hyaluronic acid, steroid, dextrose, PRP, and our target is the stem cell. Stem cell is this is very basic stuff: blastocyst, embryonic stem cell, and then this is our target, mesenchymal stem cell. And iPSC is now focusing, but problem is this is we can't do in outpatient clinic. So, and tumor burden is very high, low in here. So our target is adipose tissue and bone marrow. This is the source of the stem cell: bone marrow, adipose tissue, dental pulp, and peripheral fluid, and muscles, and placenta, umbilical cord, Watson jelly. It is what. This is the bone marrow's mesenchymal stem cell. How is it working like this way? So neuroprotective function to the nerve and neuronal protection and functional remyelination and immunological and inflammatory regulation. This is how it work in bone marrow. This is the mechanism. How about the adipose tissue? Appetite regulation and immune regulation, and sex drive, and glucocorticoid, and glucose and lipid metabolism, and reproduction regulation. And like this way, type 2 DM, we can apply the adipose stem cell to the type 2 DM, reproductive disorder, and skin healing and rejuvenation. And umbilical cord is not approved in Korea, but nowadays it is very popular in the United States and other nations. So you can use those things to the bronchopulmonary dysplasia, especially pulmonary disease. How about the source of the stem cell? Approach expansion, allogenic, or the autologous? What is the best option? And what is the key parameters of MSK delivery? Though how much volume or how much how many cells and those frequency every 1 month or every 2 months and those interval and cell suspension method. I strongly recommend intra-articular or the intramedullary injection, and those is 1 million or the just 2 million, not 1 billion. And those frequencies only 2 or 3 times per. Yeah, that's enough. And those interval is every 1 month or the 2 or 3 months. It depends on the patient condition. And which source is the best, BMAC or the adipose stem cell? This is from the review article. So they compare the mesenchymal stem cell from the adipose tissue and bone marrow tissue. Cell number is like this way. So survival rate of adipose tissue stem cell was higher than bone marrow. And bone marrow and adipose tissue, they compare the 1 billion. Adipose tissue were more effective in preventing hepatic angina, and other parties, adipose tissue is better. And how about this comparison of human adipose stem cell and bone marrow to the myocardial infarction model? Adipose-derived stem cell from a human ischemic patient preserved cardiac function following myocardial infarction. Adipose tissue is better. This 2023, this article is published. So bone marrow and adipose stem cell. What is the exclusion criteria? It's like this way. So 75 years old in category Lawrence, very early grade is excluded, and BMI too high BMI is excluded, and patient with severe varus or the varus deformity is excluded, and concomitant involvement of the ligament and or meniscus. But we have many articles of the stem cell treatment to the ligament, like the ACL and PCL and meniscus injury. And infectious or inflammatory joint disease is well controlled by the stem cell also. And this is nanopad and bone marrow procedure, and they compare. So, okay, the 1 month, 6 months, every month, your stem cell is working well. It's like this way. It's improved. Uh, in my experience, I think that if you inject a stem cell to the osteoarthritis, like to the bone marrow or the intraarticular injection, so it will last over the 3 months or it will last over the 6 months. But after the 6 months, it is not working well. Allo stem cell or the auto stem cell, which one is better? So allogenic stem cell, there are only few articles of that. Optimal cell count is like this way. So this is 1 million, and all of the articles, yeah, they only use the 1 million or the 40 million like this way. So uh, they sometimes they combine the PRP or other things. So, but in my opinion, so if you use the bone marrow, I do not recommend the PRP with the bone marrow because the bone marrow stem cell has the hematopoietic cell. But if you use the adipose tissue stem cell, if you use the stem cell with the PRP, it is better. And only the MSC plus PRP had the pain reduction and function improvement. And drug hydrotherapy, other things, MSCC with PRP, both group is improvement, but MSCC PRP in this better results. So if you want to get the good results, so if you use the PRP, they recommend that. A problem, which PRP? Leukocyte rich or the leukocyte poor, or the people if you use the fibrin plant or all things, there are many options. So I do not recommend PRP with the bone marrow. How about the autologous adipose stem cell? So cell number is 8 million or the 5 point or more numbers. So higher increase in arterial cartilage volume by MRI and great improvement. So other studies, those comparisons, so allogenic. So this is number, million, billion, billion. Okay, what's the result? Low dose is better. And this is autologous, so they use the million and 10 million like that way. So, okay, what's the result? Low dose is better. Side effect of the stem cell is like this way. So some patients get the arthralgia or the joint infusion and joint stiffness. Other problems will not consist over the 3 days, but synovial hypertrophy is very very severe problem. So if you use a stem cell with a PRP, please use the ultrasound. The lipogem system is very interesting subject because it's another generation of the stem cell because we only use the SCBF or the bone marrow stem cell, but lipogem and the nanofat is the totally different subject. So they use the mechanical device. So because FDA they prohibit the enzyme procedure. So lipogem they use their mechanical force and they made the nanofat. And this is very short time, 30 to 45 minutes without expansion and or enzymatic treatment. What's the difference? So reducing the caliber of aspirate and cannula and or their openings significantly increase in the tissue resting time and decrease the quality of the lipoaspirate cell product. Rotator blade is very traumatic to cell and produce a large amount of oil problem. So, but problem is if you use a lipogem and you only get a very small volume. So this is the procedure. So at first, I like liposuction, and then you washing like this way, and there are some beads, so shaking like that way, and you can aspirate those things. What's the characteristic of the lipogem? Mechanical procedure has been considered as low-yield method for obtaining SPF. Rotating blade is very traumatic and produce a large amount of the oil. We can't use the oil, so that's the problem. Lipogem is rich in SPF cell with a high regenerative capacity. The problem, we can't use the lipogem to the other site, like the intra intravenous injection or intraarticular injection like the way because this is very good stuff for scaffolding the problem. We can't use the fluid. How about the superpass? So adipose stromal concentration, cutting blade edge. So they blame the cutting blade, but this blade is a little bit different. So cutting blade edge do not create shear force stress or pressure damage. So before they used the only cutting edge like the tulip, so they used like the emulsification like their way. So they make the shear stress, shear force stress, and pastel is damaged. And they reported, okay, shear force is the problem, and they invented a uh, uh, very novel technique. And this is very interesting experiment because this is unshred and this is 2.0 and this is 1.5 and 1.1. And they use like this way, pass. If you use the 1.1, cell is damaged like that way. Unshred, it's only here, but 2.0, okay, lead is increased and 1.5, lead dot was more increased, and 1.1 cell is damaged. Cell is not remained well. So, okay, what's the best option for the stem cell? Because if you do not use the blade, so you get the fibrotic tissue, and this is a joint problem. Joint problem will be occurred. So they use this shear stress. So how can you reduce shear stress like this way? R3. They use the very big blade, but blade not here because only here is a shear stress is occurred, but like the big way, so the shear stress is decreased. I'll show that. Um, this is a article for the advisor to artificial nerve conduit in peripheral nerve gap injury. So this is autograft, and this is control, SBF, and this is none of that. So you guys are not familiar with the artificial nerve conduit. This is a nerve damage. So if we get the nerve from the other space, like the saphenous nerve and other space, this is the best. This is a very good candidate. But problem, so we don't have a extra nerve. That's the problem. So we make the conduit like this way. So only make the rod and nerve will be engrossed like that way. Problem is it's not working well. So they use the stem cell as the app, use the enzyme, and this is the not enzyme. This is a mechanical way. And the liposuction, they did the liposuction and the centrifugation, and they make the nerve conduit and injection. So autograft is the best way. So control is a shrinking like that way. So epineurium is not intact. SVF, very good. Yeah, very good layer, but epineurium is not intact. How about the none of that? Epineurium is very good, and the nerve stuff is very good. Preparation like this way, super packet is 10 milliliter BD, 20 milliliter BD, and composite of the agonizer. So I ordered the 200 and 100 for the intraarticular injection and the venous injection. Smart plunger, smart piston, and seeing arm as a centrifusion. My processing is a Harvard pad with the 2.1 and the 2.7 millimeter suction cannula, at least 30 milliliter. Pure pad is recommended. I inject the almost 300 tumescent to the abdomen, each 150, 150, and total volume is 300. And I lipoaspirate the like I did the liposuction almost the 120 or the 150. And then washing out pure fat is almost 40 or 60 like that. And then purified fat, centrifugation, gravity decantation, purified the filter bags, and spin. So this is procedure. S, and this is the blade. Because I talk about the shear pulse. If you use the little blade, you can get a very severe shear pulse, and they made a very big, wide cutting edge, and shear pulse is reduced. You can remember the R3. So radius is increased, and the shear pulse is decreased very severely, and fast survival rate is very good. Pass, 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 like that way. And the analyzing process for superpad is 25 times, but sometimes about how many passes the optimal? I don't know. I don't know yet. So nowadays, I'm researching the how many passes. So 100 or the 2000. So this option. So now that I'm researching. So what is the best size of the adipose stem cell, and what is the best path? So I don't know, but now I use the 20 to 30 paths because some patient fat is very smooth, but other guys fat is very rigid. So at the time, so more paths. So it depends on the patient condition. So first final 400 analyzer process the fat may lose by 30% to 60% of the initial volume. So if you aspirate the 120 or 150, so reduce the almost half or the almost one third. During the second or third analytic process, only 10 or 20%. So if you lipoaspirate the 120 or the 150, you can get the 30 or the 40 cc. And this is the last step, plunger. Very easy. Yeah, it is only take the 20 or the sometimes 20 minutes. 20 minutes is enough. It depends on the patient skill of the physician or the assistant. The processing is a centrifuge at high speed. So spin at high speed, 1,500 for 8 minutes. This point is I'm not sure what is the best spinning, but this is our standard. So I nowadays I'm researching which one is the best target. So intramedullary injection. So my researching subject is IBS chronic necrosis of the hip So I inject the adenine fat, super fat to the intramedullary. So I have several cases. And the resolution protocol with saline or PPP can also be applied for the needed indication. I do not use the PPP. I only use the PRP uh, with the DS super fat. If you want to use the PPP, you can get a very big volume. But I like to aspirate the 120 or the 150. I have enough volume. So 30 or the 5 cc to I make the SPF or other things like for the SPF for the IB or the other things because uh, over the age 60 or the 70 years old, they get the osteoarthritis, but their problem is it's not simple. They have a very complex problem like the osteoarthritis and the osteoarthritis and atherosclerosis simultaneously, or diabetes or the hyperlipidemia. So at the time, so I want to use the SPF with the SuperPad. So this is my protocol: oil, adipose, ECM, stromal cell. So I use the second layer and third layer purified with the ECM. So I use those things with the PRP and inject to the knee or the inject to the ABS site. And I get the fluid SBF. I use the 100 size. So after the 100 size fluid, I got the fluid SBF and I inject to the IV or the common carotid artery. So only one procedure you can get the SBF and the pure superpad simultaneously. How can you use the second and third layer for scaffolding? If you use the PRP or the dextrose, yeah, this is a fluid. So fluid is going out or the synovium is absorbed like that way. But if you use the scaffolding, your stem cell effect or the Prakine effect will last over the 3 months or the 6 months. How about the fluid aspect? IV, or you can mix all of things together. Kill two birds by one stone technique. This is another study. So they use the nanofat and they apply those things 3D printing model and they apply the superfat to the diabetes food problem. And they can close their wound like this way. So I'm 18 each. So 7 patients is they can close the wound. But other control group, only 2 patients if they can close the wound. On the lipogem, a new modality of fat tissue handling to enhance tissue repair and chronic food handling ischemia. So you can use the nanofat-derived adipose stem cell for the ischemia state. How about the exosome? Exosome is very hot stuff, right? So, but if you use the enzyme, exosome content is decreased. So this is non-enzymatic method or lipogem or the nanofat or the HEPA. But if you use the enzymatic method, exosome content is decreased. So if you want to use the exosome and the SPF and the scaffolding, I strongly recommend do not use the enzymatic method. Only nanofat method is better option. This is the anal incontinence. So this is this is the ultrasound. This wall is intact, but other wall is not intact. So they think that okay, so lipogen or the nanopad they apply, okay, lipogen apply, and then how can we change before treatment and 3 months is 6 months is 12 months is all of the parameters improved and they check the ultrasound again. This site is better. So if you use the nanopet or the PRP with the exogen, PRP with the nanopet, so you can get the anal incontinence or the urinary incontinence is improved. So I have many cases of that. Um, how about the stemness? If you use the lipogen or if you use the nanopad and the stemness is a decrease, no problem. So you can use the nanopad with the stemness change without change. I'll skip that. So It's control and the lipogen staminasis is intact. My tips for the best result is this: understanding the pathophysiology, or especially osteoarthritis, not for instability. Do not use the stem cell treatment to the instability. And optimal target, which one is the optimal target? Intraosseous, intramedullary. The intraarticular injection sometimes, but intraosseous injection for subcondylar sclerosis. Injection technique, I strongly recommend ultrasound guided technique because we don't have much of the stem cell numbers. So this is a limited number and very high price procedure. So ultrasound guided technique or the fluoroscopy guided technique, I recommend. Injection material is the bone marrow second or fourth, the second, third generation adipose stem cell. First generation is enzymatic method. Second generation is called culture expansion. Third generation is the mechanical way. And how optimization and scaffolding. So until second generation is the enzymatic method and the culture expansion. We do not support the scaffolding, so that's a problem. For orthopedic surgery world, we love the scaffolding because if we only feeding the stem cells, so I can't believe that the results. So patient is pain is better, but patient will get another pain after the 3 months or after the 6 months because biomechanics is not changing. But if you use the scaffolding techniques like the third generation stem cell, like the adenizer nanopath, so scaffolding technique is applied and the biomechanics is changing. Nutrition. So atherosclerosis, you can use the vitamin C, vitamin D, psyllium, and magnesium. Regeneration is the arginine, MSM, and all those things. Neuropathic pain, so vitamin B, and the coenzyme Q10 and omega-3. Exercise, I strongly recommend PNF and isometric exercise. Shockwave treatment, if you use the shockwave treatment before or after the procedure, you can get a very good result. But you can't use the intramedullary injection or intraarticular injection. You are not proud of the injection technique. Okay, just apply the intravenous injection and then shockwave apply. So 1 hour or the 10 hours later, if you use the shockwave to your knee joint osteoarthritis or osteoarthritis site, stem cell will go to there. And taping is so you can change the biomechanics. Every day I study this 4 or 5 hours for many topics like the functional medicine and the regenerative medicine. So this is my mind. I still have a long way to go, but I turn my head to the behind, so I'm only so far from where I used to be. So, and I'm proud of that. Take home message is this: diagnosis is the important part. If you apply the stem cell to the instability, you can't get a good result. And anatomy, which one is the best target? So intramedullary injection or intraarticular injection or the IV. So accurate treatment is the best option. And if you apply the stem cell like this mechanism, like the intramedullary injection and the optimal number and auto and nanopath, so maybe you can get a very good result, almost 60% to 90%. So for me, it's 70% or the 95% of the patient is better, but 5% is not better. So it depends on the condition. If you have any questions, so please send them in an email. Okay, and do you have any question?
Thank you very much, Dr. Yun, for the presentation. Now we will let the participants to ask questions in the chat group or in the Q&A. I always have these questions, Dr. Yun. So because I know you are the orthopedic trained doctors, and as pets have a lot of doctors on the doing cosmetic, and most of them they are good with fat harvesting. So what will be your advice for a non-orthopedics trained doctors to perform this kind of procedure? what kind of basic understanding they need to have for this kind of procedure?
Actually, orthopedic surgery, we are not familiar with the adipose tissue procedure, so we are worried about the embolism problem, and we are worried about the abdominal penetration or the population like that way. So we in the orthopedic surgery, we strongly recommend the bone marrow procedure. But problem is the bone marrow is if your age is over the 60 or the 70, bone marrow cell number is decreased very severely. So I do not recommend the bone marrow for the over the 60 or the over the 55. And the patient has the comorbidity like the diabetes and hyperlipidemia or other things. I do not recommend the bone marrow procedure. So at the time, I strongly recommend the adipose tissue suction because if you remove the fat from the abdominal belly and other side, your whole body biochemical mechanism is changed and posture is changed. So I strongly recommend the fat procedure for the obesity and diabetes and hyperlipidemia patient. But problem uh, for orthopedic surgeons, they are afraid to the lipoaspirate. And Ronald, where can you get cement pistons to get the SPF? So uh, uh, Peter John or the Eddie will contact you, no problem. Okay.
Yeah, I think for these questions, I think the Adenizer company that is headed by Mr. Peter Jong, I think we can get some contact from him. We have questions from, okay. Is
Okay.
it better to
Target.
inject? Yeah, I think
Mhm.
you can see the question, Dr. Yun.
Yes. Okay. Is it better to inject into the bone? Will the patient feel more pain if you inject there? Okay. Uh, if you anesthetic to the periosteum, patient is it's okay, and you use the mallet or the mallet or the other things. So uh, mm, like this way. So okay, this is the needle. This is final needle, like the gauge is a 22 or the 21 gauge. If you want to inject it here, so small lidocaine injection to the periosteum. And this is needle and mallet like this way. And needles go into the intermedullary space. So joint is here, and this is subchondral bone. So it's very close to the joint, but 1.5 or the 2 centimeter apart from the joint line. And needle is inserted like this way, perpendicular to the bone, and mallet like this way. And before injection, so you should tell this thing. So I inject there, this procedure is very painful, but it will not consist over the 1 minute or over the 3 minutes. It's only 5 seconds or the 10 seconds, no problem. And if we also inject fat tissue, do you think the residues might cause fibrosis among future? Yes, that's the one of my researching subjects. So I use the 400 or the 400 or the 100. So, actually, so before Lipogem, before Happy Pet, I used another company. I found out the fibrosis. I found out the residue fibrosis. So I do not use that material anymore. So, but I use the Lipogem. I use the Adenizer. I never met that problem. So I have almost 100 cases. So I use the nanofat to the joint and disc and urogenital diaphragm. So I use the medicine. Uh, all of my body part, no problem. How often do you combine IV and IO injection? It depends on the patient comorbidity. So patient, oh, sorry, okay. Uh, Patient has this comorbidity problem, diabetes and hyperlipidemia and all those things. So patient glucose level is not controlled well or hyperlipidemia is not controlled well. So I strongly recommend IV and IO injection. Okay. Do you have any more question? Thank you, Ronald.
And I think you
Okay.
mentioned about how to say anatomy, and I know also you are very active in running all these anatomy cadaver courses. Maybe is that a good avenue for maybe a non-orthopedic trained doctors to learn through that kind of platform to perform this kind of surgery if they can harvest the fat effectively, Dr. Yun?
Uh, for me, so I only joined the workshop, a live workshop in Korea 2 or 3 times, and then I applied the liposuction, so I get the good result. But at first, it takes 30 minutes to 40 minutes for lipoaspirate, only 50-50. Now, only 10 minutes for lipoaspirate, 150-50. So Peter Jung and the other guys, yeah, I showed that. So only 10 minutes, so injection, tumescent, 300 cc, and lipoaspirate. Yeah, so it depends on your background. So orthopedic surgeons, so mm, do not recommend the workshop, but not for the surgeon. So I strongly recommend the workshop because if you are not familiar with the operation, if you are not familiar with the anatomy, should join the workshop. I strongly recommend 2 or 3 times is better for your career because if you meet only one accident, it ruins your career. I don't want to do that accident. So I strongly recommend 2 or 3 workshop and caliber workshop or the live workshop, 2 or 3. And then if you have the supervisor, so okay, let's do like that way, and then go to your clinic and let's do it.
Mm-hmm. I think this is also one of the I personally have a lot of interest into all this osteoarthritis treatment, especially with the fats platform. We are talking about adipose tissue, and in your lecture you do mention a lot of emergence of SPF as the injection material. Yeah. So are there any more questions from the floor before we let Mr. Yun to go for his dinner? So, nevertheless, thank you very much, Dr. Yun. And for most of the participants, I don't know about whether I think Dr. Yun will be presenting online during the fest that is going to held in Bangkok on the 28th to 30th of June for the main conference. And this year we have the post-conference masterclass cadaver, which is related to facial and also breast. But I think next round we try to also incorporate your kind of cadaver teaching into our program, Dr. Yun. All right.
Yeah.
So, yep. So are there any more questions from the floor before we close the session? All right. So if that is the case, this whole webinar is recorded. We will send to the participants. You can send us your email or your contacts. We can send these recorded sessions to all the participants. All right. So thank you very much for all your precious Sunday's time to attend this almost an hour session by Dr. Yun. And please log on our website, www.facts.my, if you are interested to join the upcoming Fest Bangkok 2024. So with that, thank you very much, gentlemen, and good night. Thank you, Dr. Yun. Okay. Okay.